It's truly an honor and a privilege to be here with my co-host, José Esparza, having listened to the phenomenal presentation by Dr.Hotez, Dr. Heidi Larson, and now the video by David Bloom, which helped put a lot of this in perspective. But I would be remiss if we don't talk about the underlying problem that leads to so many of the issues that we're facing right now, and that's leadership. Leadership has been the reason that several nations have failed, including my own. We continue in the United States, a country with tremendous technology, knowledge, skill, and what have you, to be using any useful metrics, such as the number of tests performed per infected persons, at a rate that puts the United States below Kazakhstan, Zimbabwe, and Ethiopia. This is a question of leadership. If you want people to accept vaccines, you do have to answer the questions that Heidi has posed, and you do have to explain what the seriousness is, and we should not be so lackadaisical about implementing the things that must be implemented at public health measures to halt this pandemic. These things are the reason that there is vaccine hesitancy, because of the confusing lack of science that has been portrayed. And don't knowledge or not suffer for it. Now, having taken this moment to voice what I think is the most underlying problem that's going on here, this failure of leadership, I now will, with great pleasure, announce our speakers, who include the phenomenal Dr. Edwin Asturias, who's a professor of pediatrics and epidemiology at the University of Colorado School of Medicine and Public Health. And Dr. Asturias is a chairholder of the Jules Amer Chair in Community Pediatrics, and it's a pleasure to have him with us. In addition, we have Dr. Peter Figueroa, a member of the Technical Advisory Group of TAG for PAHO, and a professor of public health and epidemiology and HIV at the University of the West Indies in Jamaica. Dr. Figueroa is a professor of public health, epidemiology, HIV at the University of the West Indies in Jamaica, as I said, and in 2019, the World Health Assembly recognized him as a health leader for his substantial contributions to public health in Jamaica, the Caribbean, and the Americas, and all over the world. It's a pleasure to have you with us, Peter. I also, of course, Dr. Peter Hotez, who needs no further introduction, my good friend and colleague, Dr. Hotez. We'll move on to Dr. Ruiz Matas, who is Chief Unit of Comprehensive Family Immunization, Department of Family and Health Promotion and Life Courses of PAHO. In 2014, the Commission of the Mexican Public Health Society awarded Dr. Ruiz Matas the 2014 Sanitary Merit Medal in recognition of his extensive and exceptional career in public health, and for the indisputable contributions that Dr. Ruiz Matas has made, both for the Mexican Society of Public Health and to the field of public health. I'm also honored to introduce Dr. Robert Tapia, who is a medical specialist in health policies. He has a master's in public health and science from Harvard and a doctor of public health from the National Autonomous University in Mexico. He's a member of the Permanent Advisory Council of the Mexican Society of Public Health and a member of the National Academies of Medicine and Surgery and the Mexican Academy of Science. Dr. Tapia is a professor of the Faculty of Medicine and a visiting professor at Florida International University. Welcome, Dr. Tapia. Also, we have the wonderful Mr. Thomas Cueni, who is the director Global Association of Research-Based Pharmaceutical Companies and Associates, which is based in Geneva. This has official relations with the United Nations and contributes to industry expertise in many, many ways. I could just go on and on about all his qualifications, which are outstanding. I will now step out and let our wonderful speakers, our panelists, begin. Dr. Ed.
Thank you, Dr. Marty. Thank you to my colleagues, who is truly, as you mentioned, a panel of experts and experts in the process. So I think you asked us today to look at what will take to go from vaccine development for the COVID vaccine to the process of implementation at the level of the national immunization programs. And with that, looking at what are the expectations, what are the potential applications, target populations, and the challenges that countries and regions will face on this process. And perhaps I think that's it's fantastic to have had Peter, David Bloom's, and Heidi Larson's lectures before, because it outlined for us from Peter's sort of overview of what the vaccine development is right now to Heidi's looking at how the consumer, ultimate consumer of the vaccine is sort of facing this in terms of confidence. And finally, David, in terms of the challenges, in terms of the development of all the aspects that will convey the deployment of this vaccine. From my standpoint, I think there are a couple of things that I want to bring to the discussion. The most important, I think, for us in terms of the vaccine is that at this point, even though it is implicit in the development of the vaccine, we have yet, from the public health standpoint, looked at what's the major outcomes that wanted to achieve with a potential COVID vaccine. I think it's implicit because we think that the implicit outcome is probably the reduction of mortality and the severity of disease of COVID, but that impacts the way that we're going to look at this vaccine in terms of what population should be targeted for it. So if the major aim is to decrease the consequences of COVID infection, then we need this vaccine to be a vaccine that is going to work well for the vulnerable populations, and that is special groups like the older group over 80 years of age, and then people with premorbid conditions or conditions that sort of put them at risk, as well as pregnant women. And so very important, because vaccines traditionally get developed in healthy adults, but fortunately most of these vaccines in development are including rapidly the older age group, which will allow us to have information of how effective and safe the vaccine is in this group. But there is a second point to that, and the other piece is, do we know anything about this vaccine in terms of a decrease in transmission? We know, and we have experience with different vaccines that we have used for epidemics, where perhaps some of the outcome is to curb mortality, but one of the most important impacts that we have had is in what we call the direct effect of vaccine, or meaning the decrease in transmission. And for that, that's a key issue, because overall right now, I think we have some preliminary data, but not full data, of who are really the drivers of transmission of this virus. We suspect, because we were a completely naive population, everyone is potentially a transmitter of this virus. However, there is very recent data from contact tracing in India showing that from a 3 million contacts that they follow recently, they ended up showing that 70% of those cases didn't transmit the infection anymore. It was 8% of the population that was infected that was the super spreader, if you want, the one that sort of continued to spread. And finding out those super spreaders, what are they events? Are they just because these people move more and therefore have more contact with people, or do they have any special sort of aspects that will make them super spreaders? And in that case, if the COVID vaccine shows to be a vaccine that decreases transmission or shortens the virus, the transmission of virus you can have, you can also target those super spreaders if we were to identify them and know who they are in terms of population aspects. And then I think challenges that the immunization systems are going to have. There are many unknowns. I mean, David Bloom clearly outlined all the aspects that are being sort of developed at the same time that we're developing the vaccine in terms of the infrastructure and the capacity. But I think Heidi touched on something that is very important. This vaccine is going to be is going to need a very well thought out risk communication plan. We do believe that people are eager for sort of getting a safe and effective vaccine, but a risk communication plan has to be effective. Fortunately, the American region has had in the past experience with this, with the major campaigns that were done for measles rubella and the elimination of congenital rubella syndrome. We were able to immunize millions and millions of adult population in a matter of a couple months just by deploying the Amer vaccine. And that was accompanied with a huge effort in terms of doing risk communication and that process. But I do think that there is also another challenge that many countries like Guatemala and others will face, and that is learning what proportion of the population are still susceptible to this infection. By the time we get the vaccine in many regions, especially the Americas, it's going to be probably first, second quarter of 2021.
Thank you so much, Dr. Asturias. Thank you so much. We need to move on because we have so many questions that we need the panelists to ask, and we need everyone to have their chance. One of the key questions that people need to know, thank you so much, is what is the role that Kovacs will have in the speed of vaccine development? And does anyone want to volunteer a response? The role of Kovacs. Mr. Thomas. Mr. Thomas Quinn.
The reason why I volunteered is ICMA is a founding partner of ACT-A, the collaboration between WHO and many specialized organizations, and we're also a founding partner of the Kovacs facility. I mean, the Kovacs facility is a unique, unprecedented partnership because CEPI was only founded 3 years ago, and within 3 years, it's now challenged to deliver something which we never had in this sort of magnitude, because COVID-19 has impacted us, I think, as no other pandemic since the Spanish flu in 1918. And when you look at the fastest ever developed vaccine took 4 years for Ebola, we are now talking about 12 to 18 months for the first COVID-19 vaccines reaching people. And I think that was a number of elements. And the Kovacs comes in because CEPI did build up a portfolio of now 9 candidates in clinical development. One of the challenges for CEPI was it had to do so at a time when it was not well funded. Therefore, it was challenged to provide the funding. Because when you look at the only way to speed up development as much as we do now is to risk share between manufacturers and organizations such as CEPI or BARDA or others. It is also to do things in parallel rather than in sequence. It is to do things much faster than we normally do. And one couldn't do that, by the way, without an enormous collaboration also with regulatory agencies. I've never heard industry praising regulatory agencies as much as we have done over the last few months, not least also for the scientific rigor the regulatory agencies bring. And Kovacs actually gives countries, on the one hand, rich countries, a chance to hedge their risk, because with the exception of the United States, not a single country, probably not even the European Union, has the bandwidth to buy into as many candidates as you need to make sure that you do have a successful vaccine at the end of the day. But second, it is unique in terms of the solidarity, because the Kovacs facility, in contrast to what Gavi normally does, it is not just rich countries subsidizing or philanthropic organization subsidizing, it is rich countries buying for themselves and cross-subsidizing poor countries. Now, we have had many concerns about vaccine nationalism, which I share. At the same time, if Kovacs reaches the objective of getting 2 billion doses to people by the end of next year, I think never before we had so much success in an international collaboration. The manufacturers are crucial because, as was mentioned, The lead of the Kovacs facility are CEPI, Gavi, and WHO, but partners of it are IFPMA, representing the innovative manufacturers, but also the developing country vaccine manufacturers network, and we all put in one string. We all basically work 24/7, have meetings on Saturdays, Sundays to make sure that we move forward.
Dr. Thomas, can you get closer to the microphone? We're having a hard time hearing you.
I will hopefully, I'm sorry. We are really trying hard to bring the vaccine. I think there are just two elements which I'd like to mention, picking up on what Dr. Green and Dr. Larson said. One of them is we really need to make sure that the vaccines which reach the patients are tested for safety and efficacy. The interest in speed, one does not cut corners, that the regulatory agencies can do what they need to do, which means rigorous validation of clinical data. And we need one to move as fast as possible, but as slow as needed.
Thank you so much, Mr. Cueni. That is absolutely vital information, and we very much value it. There are many questions coming in about the issue of vaccine hesitancy. There's a commentary about the work that Dr. Larson presented, specifically about the need for increased use of health behavior theory and how that might be applied to this. Dr. Hotez, can you perhaps elaborate on your thoughts on how to get past the vaccine hesitancy?
Well, you have to break it down into two components. One, there is this underlying anti-vaccine movement and conspiracy theories and people who are generally distrustful of vaccines. And then layered on top of that is the fact that people are concerned by all of the miscommunication coming out of the White House and elsewhere. They just have some genuine concerns about COVID-19 vaccines that's actually somewhat more warranted because there's concern that there's being rushed. And the problem is that there is a communication vacuum that since there is no major communication plan really in the Western Hemisphere around, especially with the Operation Warp Speed, there was never a communication plan. It's being left to the pharma companies, which are not doing a good job. We have the AstraZeneca CEO who recorded the conversation with his investors. That was the communication around the AstraZeneca vaccine. The Moderna company has fumbled the message because of stock trading and conflicts of interest. So it's not gone well. Has to happen is the U.S. government needs a bold communication plan and strategy to explain to the American people on a regular and periodic basis. That also needs to be done in parallel with the Pan American Health Organization, because right now there's a vacuum. And the vacuum is being filled by a very aggressive anti-vaccine movement that's now expanding their remit to campaign against mass and contact tracing. So it's a whole anti-science confederacy or empire with 480 fake anti-vaccine websites. So we need to fix that.
Dr. Hotez, what can we do to increase the problem isn't leadership, Dr. Hotez. It's not just what the individual companies say, because people are going to distrust the company to some extent simply because they see a money interest. So we need to have leaders in science providing the information throughout the countries, throughout the nation of the Americas, not just in the United States. And political leaders need to understand this. What can we do to move in that direction? Because that's the key.
Yeah, Dr. Aileen, could I come here, please? Peter Figueroa here.
Yes, Peter, please.
Yes, so I agree with you fully that the role of leadership is critical. And when we look at the response globally to the COVID pandemic, we must identify that many of the female leaders of different countries, New Zealand, Germany, other countries, have shown what it takes to deal with an effective response to the pandemic. So if we then look at vaccine confidence, I would like to underline what David Bloom was saying and link it to your point about leadership. We've got to have many more voices, not just pharmaceutical companies or public health leaders. We need a variety of persons who are trusted in the society and leaders in the society to talk about the importance of vaccines and to stop undervaluing vaccines. The value of vaccines goes beyond the prevention of disease and death. There are also many indirect effects because it allows us to keep people healthy, keep them at work, keep the essential services going, and keeping the economy going. We also need to be more transparent and share information. One of the things that concerns people with the development of the COVID vaccine is it appears to be so rapid. But if we explain that this is partly because there has been so much work been going on already with other coronaviruses. The SARS virus, following the outbreak 15 years ago, the MERS virus. Scientists have been working on these coronaviruses to get a vaccine so they can take that work and apply it to development of the coronavirus vaccine, of the SARS type 2 vaccine that we're dealing with to develop to prevent COVID. My final point would be that even where there is significant resistance to the vaccine, we can learn from what happened in the Ebola outbreak in the DRC, where Heidi indicated that 17% of people strongly disagree with the COVID vaccine. However, even a higher proportion of people in DRC did not want the Ebola vaccine. But once it was explained to them carefully, and they saw from their own experience that it made a difference, then the Ebola vaccine was used to stop the epidemic of Ebola in the DRC. Thank you.
Thank you so much, Peter. That is phenomenal.
Aileen, Dr. Marty, if I could just make one additional statement. I think, again, there is this vacuum that has been left to the pharma companies, which is not adequate. I agree. We need science leadership. But the other piece to this is, we're talking today a lot about behavior change and messaging. And remember, any message right now is a message in a bottle in the Atlantic Ocean, because we have this aggressive anti-vaccine empire now with 480 websites. They dominate Amazon. Amazon.com is basically an anti-vaccine site. They dominate social media. And until we have an international effort to take down the elements of the anti-vaccine empire, the message is not going to be heard. It's too pervasive, too aggressive right now. And so far, none of the, most of the UN agencies, most of the US government certainly, and most of the foundations have not had the appetite to want to confront this and take this on. And this is where I think we have to put some energy into now.
Dr. Hotez, I could not agree with you more. It's more than just an anti-vax movement, though. It's an anti-science movement. And unfortunately, there are leaders in various countries, including the United States, that have chosen to take anti-science stances and do not promote critical thinking in their nations. Ahora, háblame de eso, Dr. Ruiz Matos. ¿Qué es lo que está pasando en México específicamente con este problema de los líderes que no dan las cosas? Y también qué es el impacto de la pandemia en el cubrimiento de otras vacunas en México y en otros sitios. Y por favor, respuesta en inglés.
Thank you for your question, Aileen, and it's really, really important to take in consideration this. Because It's the situation of the pandemic in the America, in all the world. It's impacting very, very high the programs in the of the immunization program. We have experience with the Ebola situation, for example, in DRC, where we have a big problem after the vaccination with Ebola. The number of cases of measles growing thousand and thousand of in DRC. And the reason in America, in all the world, is the same. The information that we have now for the countries in the America is the estimation that more or less 90% of the immunization service had some level of affectation in this moment of the pandemic, principally in May and June. And the people did not attend to receive the vaccines at the moment because they are with the lockdown policies in the countries, with the problem with the transportation. But they are thinking that they are in risk to be infected with the COVID if they attend at the health centers or they go out of the home. But now with the data that we have from 25 countries in the America, we are looking that in May and June, the reduction around the 20% of the coverage of the measles vaccine in these countries in general. But there are some countries that the reduction for the third doses of DPT vaccine is more than 40% in comparison with the number of doses that they applied in the first semester of the last year. This is important that is not looking only the affectation of the pandemic. We need to be ready in the affectation that we have in the vaccine preventable disease and the immunization program. This misinformation that we have now about the potential COVID vaccine is affecting the immunization program in general. We need to be clear. We need to maintain the leader. We need to maintain the good message and to be clear that the vaccines save life, that the vaccines are safety. We need to work a lot in all the levels, political, in the community, with the social civil organization, in the schools, and the health workers. It's very, very important to work with the health workers because the health workers are the population to share this information with the population. Over.
Thank you. And I could not agree with you more. And let me dovetail on that to ask Dr. Tapia Conver, what can private sectors and the foundation do to increase the immunization coverage? And as he said, with the importance of healthcare workers, is there enough coverage for medical students, medical professors, academic health centers, etc.? What are your thoughts, Dr. Tapia Conver?
Thank you very much. I think that this is crucial. I think we need to take the opportunity of what academics and other non-governmental organizations can provide. And I would like to follow on what Dr. Ruiz Matos was mentioning. I think that we can start to really seriously think about the importance of the academic platforms that need to be conveyed in order to guarantee that health personnel is well informed and that they have the elements in order to explain in general the benefit of vaccination, but in particularly in this case for the, I hope, future vaccines against COVID-19. So I think that's a crucial point that we need to emphasize and to really reinforce, because that's also an element that goes against hesitancy and against resistance for the communities to receive a vaccine. So that's one point. The second point is that teams and vaccination teams need to have the resources in order to provide in a very safe and complacent way the delivery of vaccines. We're always thinking about the safety of vaccines and the efficacy of vaccines, but that also implies to consider the infrastructure that it's in place. And one of the elements that I think we need to really think about, and I think COVID has brought on again, is the tendency to reduce investments in health in general and in vaccination, with a reduction in human resources, reduction in capacity of cold chain, reduction around the way that it can be vulnerable populations and hard to reach population can be reached. So I think those are elements that need to be put, and not to just look at the elements of vaccine efficacy and safety. It implies the last mile process of that vaccine, and it's not well stated from my point of view. And lastly, I would like to emphasize also two elements. I think that we are always talking about misinformation, but one of the elements that we have also about relatively misinformation is around surveillance systems. That's also been impacted. Are we measuring the quality of surveillance systems? Are we measuring the quality of the information systems to measure coverage? I think that's another element that needs to be put on the table, and to have, besides the communication plan, which I totally agree, I think it's going to be crucial, we need to think about other resources. And lastly, I think that we are always thinking about the money needed to buy the vaccine, but what about the other supplies, syringes, and all the elements that go around a vaccine, and that has to be part of the same financial pressure that any government is going to have. So thank you. It's been a pleasure to share this session with all these colleagues, and which I really appreciate and respect.
Thank you, Dr. Tapia. That's, you're absolutely right. And in fact, you bring up some issues when we talk about supplies. Does using all the syringes for COVID vaccine means that there's not enough syringes for other purposes? And in general, has there been a good and intensive campaign to make sure that we maintain health in other areas, vaccination of other diseases, while we're building up the capability to manage COVID-19?
That's right. I think we need to also, as Dr. Ruiz Matos mentioned, the impact, the let's say the external impact that that COVID in this case is going to have for the capacity for immunization programs to maintain a level of proficiency that it can overcome the problems of lower coverage due to the lack of let's say, capacity to reach communities or the people to go into the health units to be vaccinated. So we need to consider the whole spectrum. So I would like to pose that we take the message that, yes, we have to be looking at the communication that pharmaceutical companies have, but we have to consider the communication, as you mentioned, of the local leaders, the communication of the regional leaders. And besides that, is to really have a spectrum of safety vaccine, but it needs to be taken to the moment that it's going to be applied. And all the elements there, let's not lose focus on each one of them, because they're crucial. It's a crucial change of life. It's not only the vaccine, it's the crucial change that makes vaccines life savings.
Dr. Tapia, that's absolutely brilliant. You're so correct. Right now there are 5 vaccines in the world that are approved for early or limited use, some of which never went to phase 3 before they started distributing in their countries, such as in Russia. Do you think that this is going to putting things out before it goes through the phases, as you've talked about, is that going to lead to potential problems if one of these too early release type of vaccines leads to severe problems? What do you think is the way we should approach what's going on, and how we get the message across? Wait a minute, there are completely different technologies. People don't understand the differences between the technologies used in various vaccines, and somehow they need to understand that COVID vaccine A and COVID vaccine B are not necessarily the same in terms of efficacy or risk. And I throw that out to the panel. Perhaps Dr. Figueroa?
Yeah, well, this is a very important problem. I don't have enough information about the Russian vaccine and what they're doing, but they do have experience in developing vaccines. Um, Peter referred to the collaborative approach between Sabin and many years ago the Soviet Union, as well as the collaborative approach in relation to the smallpox vaccine. So I thought he made a very, very important point that when it comes to health, we must collaborate, set aside differences, and collaborate in the interest of everyone and every country. Now, I think the regulators of vaccines will play a very important role here. And the WHO has stressed that they're not going to pre-qualify or um, support any vaccine where the regulators have not ensured that the studies have been done and that the vaccine is both efficacious at a certain level. They've set at least 50% efficacious, as well as safe. Otherwise, it's not going to be supported for use in countries. So I think we do have in place measures to safeguard and ensure that an appropriate safe vaccine is provided. And the scientific community is going to be watching this very closely. Thank you.
So let me dovetail on what you're saying there and ask specifically about efforts by the World Health Organization and PAHO in particular regarding trying to quench the problem of vaccine hesitancy. Perhaps Dr. Ruiz Matos would like to address that?
Yeah, thank you. Yes, like you say, like Peter say, it's really, really important to be clear about all the process of the safety of the vaccines. Now, like Dr. Hotez and the other speakers said, all the people are looking now what is happening with this vaccine, and in the surveys that we know now, the people don't like to receive the vaccine because they say that the vaccine is not going to have all the process of the safety research and all the prequalification process. But now in the America, we need to work, not only in the America, in all the world, but specifically in America, we need to work more about to give the information of the population and to take the decision what is the benefits of the vaccine. And with this, we need to stop this hesitancy. But to have this hesitancy, we need to be consistent in the rulers that we apply for the use of the vaccine. With this vaccine and other vaccine, is necessary all the process of the research finish and to have all the data to give us the evidence about the effectiveness, about the safety, about the possibility of the use in the population. And PAHO specifically are working with all the ministers of health before to have this vaccine, how to increase the confidence in the vaccine. But not only this vaccine, in general, in the vaccines. And it's necessary to show not only to save lives, is to show that the vaccines in the process of the production and the process of the research are safety. This is important for us.
Thank you so much. And I have a comment from Mr. Cueni saying that WHO is looking at 70% for efficacy as the threshold and that was what was approved by the Stringent Regulatory Agency, SRA, as a condition for being COVAX. And that's much better than what some nations are advocating. And I'm very glad to hear that. Thank you, Mr. Cueni, for that commentary. Peter, I want to go to you and ask you about, we know that the ones that are higher up in clinical trials are mostly intramuscular. Some are double dose, some are a single dose. But there are some vaccines coming down the pike that are oral vaccines, some that are sub-Q, et cetera. Do these different methods, do you think, do these different methods, these different schedules of vaccination and the different methods of providing the vaccines, are those going to have an impact in vaccine hesitancy? Are they going to have an impact in compliance overall in the use of these various vaccines?
I'm sorry, who did you ask? You asked me?
Yes.
Okay. Yeah, I think one of the things to recognize is we really don't know the performance of these vaccines, and we won't given how accelerated things are, we won't fully know for a year or two anyway, and especially in terms of durability. So, for instance, it's quite possible that, especially with some of the newer technology vaccines, that we don't know if they're going to give long-lasting virus-neutralizing antibodies and protection for a year, 2 years, or maybe something that's quite a bit less. So I think the first point is that many of these vaccines may need boosters, and then if you boost, do you boost with the same vaccine or a different vaccine? New vaccines will be coming down the pike continuously. So the first Operation Warp Speed vaccines, the 2 mRNA and the adenovirus vaccines. Later on next year, we may have the live virus Merck vaccine. We may have the Sanofi, the Novavax vaccine. So it's going to be a very complicated and very complex ecosystem of different vaccine technologies. And right now, the community, and as you point out, potentially mucosal vaccines or other delivery mechanisms. So there's going to be an unprecedented array of technologies at a time when our communication is highly deficient. And so there's a terrible mismatch between all of the array of the technologies and the communication surrounding it. And so it's going to require the public in general is going to have a lot of situational awareness and stay connected to the news. But it's going to be an incredible challenge for governments and for WHO and Gavi and UNICEF to have that level of communication. And right now it's not there. Right now, the US government, as I mentioned during my talk and afterwards, there is no communication plan for Operation Warp Speed. It's being left to the companies. They're fumbling terribly at the messaging, in part because they're not vaccine companies. So they don't, I think what people need to understand is how fragile the vaccine ecosystem is. And it doesn't take much for a vaccine to be voted off the island because of public misperception. We've seen this. We've seen how the Lyme disease vaccine has fallen off because of absent communication, or one of the rotavirus vaccines. And that'll happen to some of these COVID vaccines. Even if they're good vaccines, they may not be used unless we communicate better.
Thank you. Thank you. That's true. I'm going to throw something else at you, and that is one of the reasons that the oral polio vaccine was used for so long, not only because you get a whole other level of immunity, that mucosal immunity, as well as systemic immunity from a live oral vaccine, but you also inadvertently, especially with normal or lack of hygiene normally, pass that vaccination on to others in the fecal oral route, right? So what would you say would be the value of if we can have a safe and effective mucosal vaccine over a 2-dose injection vaccine in terms of getting that vaccination higher level of herd immunity overall?
Well, I think it's an interesting idea. As far as I know, the only live vaccine coronavirus vaccines being looked at is that Codagenics has a live vaccine. The Merck VSV vaccine probably would not meet those specifications. I think right now it's all hands on deck trying to get at least a couple, 2 or 3 vaccines through conventional delivery routes that we know actually work. And I think that will happen. And then trying to accelerate this as quickly as possible. But it's going to be a daunting project. The good news is that I think a year from now, the world will look much better than it does right now. And 2 years from now, it'll look better than it does a year from now. But that's the kind of time frame we're talking about. We're not talking about weeks at this point.
Well, I agree with you, Peter, and especially when we consider that it isn't all about vaccines, it's also about the newer treatments, which use immunology as well, creating, for example, specific targeted monoclonal antibodies, which are very useful. Mr. Thomas, there have been some questions about what you meant when you were talking about the 70% efficacy threshold. They want to know if the efficacy is referring to prevention entirely of manifesting illness or prevention of hospitalization or both.
Really, many questions were unanswered for at least a year or long ago. Now I faced a problem with my mic. I moved this side.
No.
I leave this to
You have echo.
Dr.Hotez to yes, but that's fine.
So if you could type in your reply, I'll read it out. And meanwhile, Dr. Figueroa, I think you had a comment on this.
Well, I thought that the assessment was that it would be 50% efficacy. I wasn't aware that the WHO had said 70% efficacy. There are some modeling studies to show that a vaccine of 50% efficacy could still make substantial contribution to protecting the elderly and reducing the number of deaths among the elderly and others with comorbid conditions. So
That's
I
true.
would have
There is a fundamental problem with a 50% efficacy, and that is that we will have to continue using the facial coverings and other protective mechanisms because anyone will be aware that they have individually, at best, 50% efficacy. But the true question wasn't about the overall efficacy, it was what kind of efficacy, right? Whether the WHO was looking at efficacy specifically to manifesting any illness at all or hospitalization, because we do make that distinction for a number of vaccines. Dr. Hotez, would you like to weigh in?
Yes, happy to. I think, we did a modeling study with a group at City University of New York and found that we need, even if you have a vaccine with pretty high efficacy, you're still going to need a high level of vaccine coverage, at least greater than 70%. And as I mentioned, that assumes that you have a vaccine that actually blocks infection. But remember, the target product profile of a lot of these vaccines is, at least to begin with, is to reduce severity of illness, which may only be partially protective, and you may still be shedding virus even after getting vaccinated. So again, we're not going to have a full understanding of these vaccines probably on how they're operating until after they're licensed. So the level of monitoring is going to have to be also, in addition to the communications problem that we're talking about, the level of monitoring is going to have to be really extraordinary to follow to see if they actually are blocking infection and whether we can interrupt transmission. But for now, what it means is we have to assume that many of these vaccines will be only partially protective. People will still shed virus, and what that means is that these vaccines may not be replacement technologies. They may be companion technologies that are used alongside the masks and the contact tracing and the social distancing and all the things we're currently recommending. And again, that is also not being really communicated. Unfortunately, the White House and some other governments tend to like to hype the technologies and build them as miracle technologies, and it's not going to be that way. It's, you know, it's not 1956, and we're not going to bring all the journalists to the auditorium at the University of Michigan and pull back the black curtain and like so we did for the Salk vaccine, and everyone goes dancing in the streets. It's going to be an iterative, slowly evolving process that is going to be really important to make certain that we still maintain all of our existing public health measures as much as we can.
And you make some phenomenal points there, Dr. Hotez. And I think that should we then be demanding of the vaccine manufacturers that they provide RT-PCR data on upper respiratory viral load among the people that, even though they've developed antibodies or neutralizing antibodies or what have you, T-cell immunity, what have you, are they infectious? I mean, would that not be an important component then for us to understand the value of one vaccine versus another?
Yeah, and while the problem, of course, is there may not be enough vaccines for us to have that luxury of being selective. So it may be the situation that we'll have to take whatever vaccine we can. And you know what I've been saying about what I would do or recommend for my family is you may not have a huge amount of choice in the beginning, but it's important, I think, that everyone do what they can to get some virus neutralizing antibodies in their system so they don't get COVID. So most likely I will personally take almost any vaccine that has been licensed and gone through the approval process and made available, knowing that there's a possibility that the first vaccines may not be our best vaccines. And we've seen that before, right? We saw it with Haemophilus influenza type B. We saw it with the first rotavirus vaccines. We saw it with the first HPV vaccines. Better vaccines come along. But the point is, get what you can, get virus neutralizing antibodies in your system so it'll keep you out of the hospital. But then realize later on you might want to get a booster with one of the other later vaccines coming along. And again, we don't have a lot of precedent to go on about this, but again, that level of communication is going to be very important. It's clear we may not be able to rely on the pharma companies for that level of communication. It's going to put a lot of pressure on the regulators and ministries of health in the various countries, and a lot of knowledge and situational awareness and scientists that the people will trust.
Thank you so much, Peter. Thomas now has a good computer screen, and we have much better audio and visuals on you. Mr. Thomas, could you now answer the question about vaccine efficacy?
It is actually, the 50% is what the FDA asks for. The WHO, to the best of my knowledge, is 70%. And it is about developing the disease. But I would certainly agree with Dr. Hotez. Whatever we have as a safe and effective vaccine, I would personally also want to use, but I wouldn't want to rush it. That's why, in terms of the question which was discussed before, I would be extremely concerned to use vaccines which haven't been approved, which haven't gone through the proper clinical trial, phase 3, and one also needs the time to look at the results of phase 3. That's why I think the recent guidance issued by the FDA has been very much welcomed by the industry.
And the recent guidance called for 2 months worth of data, which is a lot less than we're used to in terms of really assessing safety and efficacy. Do you think, and I understand that there's even pushback for even those mere 2 months worth of data. What do you think about 2 months? Is 2 months enough?
I think what we will have to accept, and we have heard it all afternoon, this is something which will evolve. That's why one of the most important elements will be proper pharmacovigilance, proper surveillance, because there are many questions which we simply will not know. For example, the duration of the immunity. We now expect that most vaccines will need 2 doses. we may get in due course a vaccine which is just one shot. We don't know how exactly the vaccines will work on the elderly, the vulnerable population. We do not know whether the vaccine will protect the person vaccinated or whether it will also prevent transmission of the disease. Therefore, I think we have to accept that there will be many open questions. This will be an evolving monitoring. That's why also, by the way, the US has one of the most sophisticated systems on no-fault compensation, because patients, if something happens, they must be sure that they get a rapid compensation.
Thank you. That is outstanding. We have a question here. As with Ebola, the pushing of a vaccine for COVID is something that requires us considering some kinds of ethical issues. Are there going to be ethical issues with providing these vaccines that, as you say, are evolving vaccines and have less than ideal amount of safety and efficacy study?
I believe, it is, as so often, you really have to weigh the benefits and risks. Right now, we're all still exposed to COVID-19. I'm speaking from Geneva. Infection rates, even in Switzerland, are going up rather rapidly. Hospitalization rates are still very low, but we don't know how this will evolve over the winter. Therefore, I do believe that we are interested in having a vaccine as fast as possible. But for example, one of the discussions we recently had among ethics people within the industry is, I personally would be concerned if one would run challenge trials right now for two reasons. There are reasons where you can do, for example, a challenge trial with healthy volunteers, and probably would be easy to find them. But on this one, there are sufficient hotspots of infection still around the world where you can run normal clinical trials. And even for the young, COVID-19 can be a dangerous disease, and we do not have a rescue medication yet. We may have in due course, we may find out that monoclonal antibodies may become a rescue medication, but right now I would be really concerned not going also through the proper traditional clinical trial methods.
Thank you. Well, we're getting close to the end of our session. I want to give each of you 60 seconds. Please don't take more than 60 seconds to each of you give us a key message. And I'll start with Dr. Hotez, who says he's on a very tight schedule. And then we'll go to Dr. Figueroa, Dr. Asturias, Dr. Ruiz, Dr. Tapia, and back to Mr. Thomas Quincy. Thank you so much, each of you. Peter, you have your 60 seconds. Oh, he's disconnected. Okay, Dr. Figueroa.
Yes, well, I think it's important that we recognize that COVID is going to be with us for the foreseeable future. It's going to take time and collective concerted effort for us to manage this pandemic in a way that will protect the vulnerable and ensure that we could reduce deaths and keep the economy going. From what I can see, the scientific community has been working very hard to produce safe and efficacious vaccines. The regulators will monitor these, and we have a responsibility to be transparent and communicate effectively with our people, our populations, to explain to them, once we have a suitable vaccine, then we've got to explain to them the value of taking it. However, it is not going to be a panacea at this time. We are going to have to continue with the non-pharmaceutical measures, the masking, the physical distancing, the hygiene. So it is important that we all work together and ensure that in the allocation of the vaccines internationally between countries, that we pay attention to equity, because right now many countries, developed countries, are ensuring that they will have vaccine, but there are many countries through the Kovacs mechanism, they'll have to depend on getting their vaccine. And within countries, we have to ensure that the most vulnerable get it and that there's an approach that takes into account equity. Thank you.
Thank you very much. Fantastic. Dr. Asturias?
Yes, I'm going to build on Peter sort of saying that we're in an unprecedented time right now. I mean, this pandemic has really challenged humanity in many aspects. Ask us to remember that we developed things when other infectious diseases were really threatening the population, and that I want to go back to polio vaccine, to measles vaccine, and so even the meningitis vaccines for Africa. And I have to say that we as humans have put together scientists that really are doing this job very responsible, are to the ethics of individuals as well as the population. There is an committee have to protecting the health population, and let us just make sure that when we develop this vaccine, lead by scientists and developers, this is done safely, and whenever it's going to be released, done in a way that the population is ready to take care of to master risk. We have an obligation to the public health, and we have an obligation to science to do.
You're absolutely right. Thank you so much. We do have an obligation to do it right. Dr. Ruiz Matas, can you give us your final thoughts?
No, thank you, and thank you for this opportunity to have this important discussion battle. At the same time that we have this challenger about the hesitance or other topics about this vaccine, we think that it's a big opportunity to give the information of the population and the leaders that what it's important, the immunization program, and to look not only to save lives by COVID-19, that it's necessary to maintain the immunization program to save life for measles, rubella, and etc., etc. I think that it's opportunity, and now we have the opportunity that the people understand what is the benefit of the vaccine, but at the same time, it's a compromise to take the decision with the evidence that we have, with the science that we have, and to be clear with the population, and to be clear with the population about the safety of the vaccine and the benefit of the vaccine. It's necessary to take again the decision of the use of vaccines are the people to have experience in public health and to know the science and to not to take the decision at the political level only. It's one point. But the other point, it's important to understand what is necessary to support the operational issues at the country level. Because we need to have this vaccine not only in the laboratories, we need to have this vaccine on the most remote area in all the countries in America. No? And for this, we have to work very hard with the health workers. The health workers is a very important piece of this, because it's not only people in risk, it's the people to have the responsibility to give the information of the population and to apply the vaccine and to receive the information of the population if they detect some IFE quickly. It's important. I think that it's a very important opportunity for the public health, a very important opportunity for immunization, but we need to work together and with the evidence for this. Over. Thank you.
Dr. Ruiz-Matas, I could not agree with you more. From your mouth to God's ear. And I think WHO has been very, very clear for many, many years about the importance of global action for health. And I'm very proud to be here with all of you. And now I go to Mr. Thomas to let him have the final word before we close.
Thank you very much, Dr. Marty, and it has been an honor and pleasure to be with you. I would like to leave you with just a couple of messages. One is what we have seen, and previous speakers said it, the importance of partnership. What we see, for example, in the Kovacs facility is private sector working with CEPI, Gavi, WHO, be it from industrialized or developing countries. The second one, we have also seen the importance of actually a strong private sector, because when it comes to scaling vaccines, there are not that many companies in the world with the ability of producing hundreds of millions of vaccines, and we will need not millions, but billions of COVID-19 vaccines. And the third one, I think, is the importance of equity and solidarity. And that's why I really am a strong believer in Kovacs, and I'm encouraged that we, after a slow start, we do see a coming together of self-funding countries, high-income countries, which will help to make sure that as much as possible, we will see equitable and fair allocation already next year, certainly for healthcare workers, but I also hope for vulnerable population. And that's crucial. That's also unprecedented. We never had it before.
Thank you so much, Mr. Thomas Cueni. You're absolutely right. And I think people forget that when we help others, especially when it's a contagious disease, we're helping ourselves as well. This is not a one-way street. We are a global community, and we must recognize it. So thank you so much. It has been truly a privilege to be with each and every one of you. Thank you for your comments. Thank you for your hard work. And that closes our session.
Thank you.